Welcome to NeuroNoodle's Neurofeedback and Neuropsychology podcast featuring tech legend Jay Gunkelman. He's the man who has read well over 500,000 brain scans, and Dr. Marie Swingle, author of iMinds. Our goal is to provide information and promote options for better mental health. The NeuroNoodle podcast is supported by listeners and businesses just like you.
Howdy, Pete.
Long time no see, Jay Gunkelman.
Since last night, Sky decided that this is too much action for him to sleep on the lap. He got up to go sleep on the floor for a moment.
So he's had enough of our podcast, huh? That's it? We were around last night. I don't know if anything piqued your interest. What's on your mind these days in the last 12 hours?
I do have a talk for Nick and Tiff in the School of Neurotherapy coming up, but it's a talk about the insula, basically, which is cortex, but it's buried deeper into the brain, and it's not commonly something people can see, but with special techniques and Loretta, you can end up localizing to it, and it's involved in a lot of very crucial functions, parasympathetic, sympathetic balance. It's associated with dissociation in PTSD. It's associated with interoception and visceral regulation, peristalsis, things like that are all regulated there. So a lot of people with GI problems end up having insular issues. Anyway, that's a 90-minute.
So what is this
time for questions on that?
Neurofeedback school? You said
The School of Neurofeedback, I think, is what they call themselves.
Okay, all right. I thought there was another.
Tiff Thompson has an educational, clinical bent there, and they provide a lot of good content. I think they've got a whole series of, and then Cynthia Kerson's APED, Applied Psychophysiology Education, and the Sadars from the Northeast Regional Society area have put together a series. Once they've got talks coming up, every Thursday or something such as that. And I've got a talk, I don't know, February 20th, maybe, something like that. Anyway, I have to look at my damn calendar to figure out what I'm going to do tomorrow, So I got myself too damn tightly scheduled, So.
Well, I mean, we've done the Q&As, and it seems like the same things keep popping up. It seemed like a lot of the SSRIs, the Benzos,
the difficulty is how you got there in the first place. You sent out some links to think about topics, and one of them was the difficulty of getting a diagnosis, a mental health diagnosis. Okay, the term health does not belong in there because in the DSM there isn't anything about health. This is all pathology. There isn't a normal in the DSM. You can't be classified as normal or healthy. You can only rule out all sorts of pathologies, and we all have our own little quirks. I'm sure under the scrutiny of a psychiatrist, we'd all come up with some sort of a DSM category that they'd lump us into, under their breath. Yeah, he isn't one of those, But the difficulty with the diagnosis is the lack of validity in the diagnostic. It's what the hell is validity? Fancy term. They have reliability. You run through the DSM pattern and you get the same diagnosis. If you you go through the checklist and you come up with the same diagnosis every time. So it's highly reliable. But validity isn't the same thing as reliability. There's different kinds of validity. Predictive validity is what you want. You want you come up with your valid, reliable categorization, and that should predict how you treat. And at this point, they lack that validity, and they admit it.
So it's a DSM-5. What would they need to have a 6 coming out?
Oh, the, um, a whole different orientation, and they know it. They've requested people provide research domain criteria publications, which we've done. Independent of the diagnosis, what does this lab test show, and what's it correlate with? Independent of the DSM, and they started to threaten to not fund things if they were all DSM oriented. But there's a lot of inertia. So your department at the university has studied depression, and they've got paper and pencil testing. That's what you've got to test depression. Well, how the hell are you going to get funding anymore if that's just a DSM for depression? If there's no physiologic test or genetic test or some, pupillometry, some deal, thing you can or can't do, some way to classify you. That's a valid actual test. Not a self-report or the story somebody would tell. So, you go to your cardiologist and says, "Doc, I got chest pain." If they were all given angioplasty, half of them just had indigestion. The symptom complaint isn't the diagnosis. It should tell you what tests to do to come up with a diagnosis. What's the pathophysiology or anatomical oddity or whatever it is that's causing this, and you've got to be able to do that to end up having the validity that actually can end up predicting treatment. So we have to do testing, and in psychiatry, what tests do they do? Yeah, that you can sit down and have an interview and discussion. You might have some paper and pencil testing where you're self-reporting. You may have an MMPI where they've got you criterion keyed with different behavioral clusters and so forth. But the DSM that they come up with doesn't predict the treatment, unfortunately, and that's the key flaw to their system. So if you actually do lab tests of some sort, and in psychiatry, I might suggest genetic testing is starting to be done. Are you a rapid metabolizer of serotonin or a slow metabolizer of serotonin? That might change the dose or the expectation of the result. But that's liver function. That's not really brain. And to a large extent, the genetic testing is looking at metabolic processes of the drugs that are being provided. So it hasn't really provided the psychiatric insight, that they expected it to. EEG and QEEG are also testing, and the testing there can end up being of a great assistance. I came up with the genetically linked EEG patterns that predict treatment, the endophenotypes, and 2 were known endophenotypes at the time. I predicted 9 others that have been validated as endophenotypic, and if you're in one of those clusters, you respond to things the same as other people in that cluster respond to. So you can start to make predictions based on the observation of, that cluster responds to this. and the other cluster respond to something else. So, and behavior, unfortunately, doesn't always categorize you. And even the DSM is a little shy of characterizing everything fully. OCD in the DSM, one kind of OCD.
Only
We
one?
yeah, exactly. After all these years, you'd think they would have multiplied to 2 or 3 at least, but no.
People asking about the withdrawals, the brain zaps. I've never heard of brain zaps before. I thought that
Yeah.
was kind of interesting. Is it possible to start with panic attack? Because generally people take these things to stop panic attacks. I know generalities we don't like, but I'm just saying
So,
more often, because if you feel like you're going to die and have a heart
so
attack, you're
you
pretty
start out
motivated.
with anxiety. Usually, anxiety is associated with over arousal, but it can also 12% of the anxiety complaints end up having epileptiform discharges. 12%. Now you think, oh, well, that's not very many. What are you complaining about? Well, the normal background population has 3%. So 12% is a 400% increase above baseline. So you can think of it as not very often. But if they have panic, the percentage goes up to about a third. And now you're talking, probabilities that you're going to run into this. If a third of the people that have panic that come through your door are likely to have epileptiform discharges, it changes the kind of things you can give them. You can't give an antipsychotic drug to somebody with discharges without making it more florid as a discharge. You can make them more severe, not well-intended treatment, but you're going to make them worse. And so you have to look at the endophenotype, and if you have the epileptiform endophenotype, you end up having to treat that with the appropriate stabilizing medications. In psychiatry, they don't use an anticonvulsant to treat seizures. They're not neurologists. They're not trying to treat a seizure, but they use that class of medication as atypical antipsychotics or stabilizing agents. And the use of anticonvulsants in psychiatry is not uncommon at all. And again, they're not trying to treat seizures. If you're having seizures, they're going to refer you out to neurology. But if you have discharges in the EEG and the neurology chooses not to treat you because you're not having seizures, the psychiatrist is likely to end up treating you with an anticonvulsant as a stabilizing agent, not to necessarily treat seizures because you're not having them. Discharges that don't involve the motor strip can end up disturbing function. Posterior discharges in your visual cortex can give you distortions, hallucinations, sensory processing problems. And those were considered benign juvenile epileptiform discharges until more recently. And now they see cortical dysplasias, structural anomalies, and actually an epileptologist would choose to treat those discharges because you get an improved outcome with respect to sensory processing and fewer hallucinations and things such as that. So, it's not always benign. So in anxiety, again, up to a third of them have discharges, so you have to look at the EEG. The other thing you're going to see in the EEG, if they're really anxious and they're hypervigilant, you'll see lambda at the back of the head with the eyes open. Visual hypervigilance. You focus, 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 focus. And you're going to see lambda every time you refocus your eyes on something. You create an event-related potential, and that's seen as lambda at the back of the head. So you can see hypervigilance. And then when you close the eyes, well, you're not focusing anymore. So lambda goes away with the eyes closed. If you have visual imagery, you might have lambdoid activity, but that's not the same thing. And when you close your eyes, if you have anxiety, you're quite often, if you have PTSD and anxiety, you'll see the right temporal, the P8 or old T6 electrode location have a gigantic alpha peak. And that's a flag for social perception. And if you have anxiety, if you can't perceive your social context, it's an ambiguous circumstance that's going to keep you anxious. And you'll usually see overarousal. And that overarousal can be seen as faster alpha, and occasionally you move for the pup to jump up here if he wants here.
He
Anyway,
likes to go again. Good.
so yeah, Sky's the co-captain in this chair. So anyway, the picking of medications can be facilitated by actually looking at the brain function. 100 pounds of Rhodesian Ridgeback here, So it's a lion hunter. There's no lions in the yard, I guarantee it. So
very good. So anxiety, and it gets ramped up. You think you're going to die. Immediate fix. A benzo, right?
If your alpha is so fast, the benzo will slow your alpha down. You may be so fast that you're low voltage fast, and that's seen in alcoholism and anxiety and overarousal. And again, a benzodiazepine will slow you down to have a nice alpha. The difficulty with that is as you take the benzodiazepine, you replicate receptor sites. And your problem was you had too many receptor sites in the first place and could saturate them, and now you're making more of them. You're becoming more and more dependent on that medication, and either you increase your dose or it becomes ineffective. You become actually worse than you were before. You've made more receptors than you had, and you had too many in the first place. So now you could be a receptor vendor if you could actually pull those damn things out, But you've got an excess of them, and you have to saturate those in order to feel okay. So you're either dependent on those benzodiazepines or you learn how to do it yourself, which can be done. Neurofeedback can teach you to regulate your arousal levels so that you don't have alpha that's so fast that you're low voltage fast, or slow your alpha down so that you have an arousal level that's more appropriate. So your brain doesn't come with a owner's manual that tells you how to operate it. We all get to where we are by hook or by crook, by accident in some respects. How did you learn how to eat? Well, you threw the food over your right shoulder for a while, then you hit your head with it. Eventually you found your mouth. You learn how to operate by hook or by crook, and by trial and error. And if you don't try, you won't end up making progress eventually. But you're going to have a lot of errors in life. But it shows you're trying.
If something works really fast, that means that the odds are likely that you become addicted more to it quicker. Is that a fair statement?
Not absolutely the case. However,
okay.
It's not unlikely. Opioids, you have an immediate, gigantic burst of hypersynchronous alpha. It's really, really rewarding. It's the equivalent of post-reinforcement synchronization that's observed. When you do something that's a correct response, your brain makes a big burst of alpha as a kind of a reward. It's post-reinforcement synchronization. It's the brain saying, I got it. And that, I got it, is the rush of the opioid. But you can't keep getting that from the same dose, because again, your body is changing the number of receptor sites. And instead of doing this with your endogenous opioids, your body makes such stuff and endorphins, and you can actually do what you're trying to get from the opioids yourself. Now, if you've been on opioids for a while, coming off of them is very difficult. The same thing with benzodiazepines. You become hyper activated with the benzodiazepines or opioids. You're dependent on them, and your body's pushing back, and you've got a rebound hyperactivation. And at that point, if you pull the meds, you're going to have rebound hyper excitability that can be quite problematic. Brain zaps.
Yeah.
But I've seen people withdraw from benzos, which is really very difficult. Klonopin, very, very, very difficult. A long-acting benzo, one of the most difficult to come off of. And they'll be walking towards. I worked in the alcoholism drug division. I see these folks, and they'll crumble to the ground and have a seizure. And you try to keep them from hitting their head and whatnot, and they come to and real quick and kind of stand up and dust themselves off, and you say, Fred, you just had a seizure, and he'll look at you and say, no, I didn't. There's no memory. There's no memory of it at all. That it's a period that's wiped away cognitively. But it's extremely hazardous. You have to withdraw under medical supervision and step it down very, very carefully under observation and supervision. And if you're really hooked on it, you're in need of treatment. And if you're really hooked on it, usually inpatient treatment at least to start. It's difficult. Even coming off alcohol, it's not. If you're really, really badly addicted to alcohol, you are best advised to take some initial treatment in an inpatient setting, because the withdrawal DTs are no joke.
You can die from those, right?
Yeah, you can have seizures, and hallucinations are rampant. And if you're detached from reality entirely in a DT, having a car accident, or being out in life doing DTs is not going to work. In a hospital, DTs are even difficult. Having worked in the state hospital, we had a fellow come in rather bad shape, and he went straight to the medical ward because he was having DTs. And he was a big, strapping guy. I mean, he was big like you, but add on like a Schwarzenegger build. He was a construction guy, and as strong as an ox, and they had him in restraints in a medical bed, and he kind of came to, and he wasn't seeing what was around him at all, and he went wild and tore the bed apart and was screaming and pulling, and he just trashed the room. But then they came in and popped him with Thorazine. I was on the emergency squad and was involved in it, and he wound down, and finally, as he's coming out of the DTs, I spoke to him about what was going on, and he says, I was laying in the bed, and on the ceiling I saw monkeys coming out of the screen, and I had to, and they were attacking me, and I had to, I was tied down. I had to get away, and I couldn't get the monkeys on his back. you know, uh, uh, how Freudian can you get as a dream, But well, his hallucinations were, probably uh, colored in part by what he, had been told about the monkey on his back, But anyway, he was a once he was clean, he was a hell of a guy. I mean, a, a, a great construction worker, but he needed to get his head straight, and he was so over aroused. A low voltage fast classic alcoholic EEG, and he was one of the alpha training ones we did. And you have no alpha to speak of. We basically trained alpha at the back of the head. And when you start to produce a lot of alpha, you have learned how to control your arousal level to the point where you no longer need alcohol to calm you down. So once we got them producing a great amount of alpha, we didn't do any alpha theta crossovers. This was in the early 70s. We wrote a grant to NIH in 74 for a study, and they didn't fund it, obviously, but on alcoholics getting alpha training. And Peniston published their work in the late 80s, 88, 89, and that was alpha theta, and that came out of Menninger. But the state hospital, our lab was the first lab in a state hospital anywhere. So it was an odd group. It had us in it.
Yeah, I was going to say,
Oh,
you got panic attack. You can do neurofeedback. There's certain things that you can do. If
yeah.
you want something like an immediate fix, a benzo can give you an immediate fix. If you want something longer lasting, you can take an SSRI, but it takes a little bit longer to get
If
going.
your alpha is slow, an SSRI may assist. It does take time. It takes about 2 to 3 weeks for it to have its clinical impact assessed. And usually they want you to be on it over a month to assess whether
Yeah.
it's working or not. Um, but you can kind of predict whether it's really the right medication by looking at the EEG ahead of time. If the frontal lobe has hypercoherent alpha, that's below 10 hertz, an SSRI is appropriate. Now, if it's below 8 hertz and it's still your background rhythm is too slow, if it's 7, 8, at that point it needs an SNRI, the norepinephrine reuptake inhibitor and serotonin reuptake inhibitor mixed together into a drug. And that speeds up alpha and suppresses the coherence of alpha frontally. And if your alpha is over 10 hertz, you can't take an SSRI without being pushed into an overarousal. And people do have bad effects with SSRIs. There's warnings when you take it as to suicidality and all
Mhm.
sorts of potential side effects of overarousal, and they're well known. They come with a warning, if you actually read the warnings.
Yeah, check with your primary care physician first. This is for entertainment and
Yeah.
information purposes only.
So over 10 hertz, uh, uh, the older classes of antidepressants like Elavil or nortriptyline can work, but they have a lot of side effects. The reason they were replaced were their side effects. So they're not as often given, but Elavil is given at night, and it makes you sleepy, so you sleep, and then you have an anti-anxiety effect during the day, and it has a slight slowing to if your alpha is too fast, it has a slight slowing to it. And now their tetracyclics have replaced largely the tricyclics, and it's a newer class of medication, different chemistry, and that's trazodone or Remeron as brand names. But trazodone, if your alpha is hypercoherent up front and is faster than 10 hertz, then trazodone is a very good match, and especially if you've got beta spindles. Beta spindles frontocentrally contraindicate the SSRIs. and definitely the SNRIs. But the trazodone and Remeron can still work then.
What I'm trying to piece together is if one takes longer to get going, if you withdraw from either one, you're going to have some type of effect. Okay. If
Yeah,
brain zap, I don't know, I still don't know what a brain zap, what's going on in the
it's
head, but if that's with the slow moving one, on the benzos, I've heard and seen in the headlines where people really get suicidal if they come off of that. Is that the two different types of extremes on withdrawal symptoms?
withdrawal symptoms can end up being wildly different.
Different.
Some, well, the opioids, sweating, trembling, having difficulty maintaining control over your autonomic nervous system, the chills and diarrhea and vomiting. I mean, it's ugly. Uh, Acute withdrawal from opioids is very, very difficult, and again, it's best managed in a medical facility. If you go cold turkey, you can sometimes end up dying from the result.
Yeah, on the SSRIs, you want to like slowly get off of them, and that needs to be underneath a doctor's care,
Yeah,
right?
and
Okay.
there are studies that actually have looked at multiple antidepressants and which ones would be workable, and you had to give a long trial on one, and then they'd wean you off of that and put you onto another. And then wean you off of that and put you onto another. So they randomized the order, so there wasn't any. It was a well designed study. Martijn Arns and his group did this. The iSPOT-D study. Little I spot and then big D dash big D, iSPOT-D, and it was for depression, and they were looking at depressives and the SSRIs and which ones worked. And one of the nice things that they found was that if you had epileptiform discharges or slow focuses in the EEG, and they weren't that common, but when you have them, the only one of the SSRIs that was still effective was sertraline. Zoloft is a brand name. So that assists in selecting which one of those you might use if you have a discharge and you're treating it, which one of the antidepressants you might use if you have frontal alpha problems.
Can neurofeedback help with the withdrawal symptoms as well as the underlying symptom that you had in the beginning on the anxiety, or is it two different trainings or the same training?
It is the acute withdrawal at the beginning is hard to treat with the neurofeedback, which is a longer term learning process. You need something to help you in the short term. Occasionally another class of medication, so you're not going to rebound hyperexcitable, but it's not the class that you're on, so your body hasn't made the adaptations, and you can come down on the one that you were on, and then both of those can be pulled. And anyway, a good doctor that works in a clinic that treats addiction ends up being somebody who prescribes drugs to come off of other drugs as something that they've learned the tricks of what to use to step people down. And uh, and people can get themselves in quite the mess nowadays. There's pretty much anything you want to be finding is out there somewhere. So, uh, and probably a lot of things you don't want to find. So,
All right. If people want to get an idea of why we were talking about this, here's the link to the Q&A that we did. Check it out. We had Dr. Andrew Hill, we had Diane Kostos, of course, we had Jay Gunkelman, and we had an array of people that popped in, and this just kept coming up as a question, and we said we would address it in the next morning show, and here we are, Jay.
if you delve down deep into topics, there's some people that will follow out of interest, and in the general conversation mode, we only go so deep. And this discussion today, I think, went into a lot more detail of which one would be picked and why and when, and how addiction works and that sort of thing. My paper on treating people that had addiction, an N of 30, at the end of 1 year of treatment, all 30 still clean and sober. But, the concept of a dry drunk is out there. You can be clean and sober and really just totally a freaking mess, But you can also be clean and sober and highly functional. What was the treatment outcome at the end of 1 year? Clean and sober, yes. But we did the Woodcock-Johnson 3, which can be done on a repeat at 1 year. And they had a 21-point GIA, their equivalent of IQ, a 21-point standard score jump in IQ. They had an over 40-point jump in delayed recall. They had essentially a 20-plus point standard score improvement in all neurocognitive measures. Not only were they clean and sober, but they were doing much better neurocognitively. Gee, when you make the brain work better, it works better, and their treatment wasn't because, it's an addiction treatment center. So you'd think, oh, well, they all got alpha theta because alpha theta is what you do for addiction. Well, the study was to look at the effect of treatment driven by phenotypes, not by, standard treatment for a diagnostic category of addiction. So 2/3 of the people that came in, their endophenotypes ended up having alpha theta predicted for their phenotype. Some had some pre-treatment with SMR, but all those 2/3 ended up having alpha theta. The other 1/3 of the addiction had an anterior cingulate problem, and they wouldn't have been effectively treated with alpha training or alpha theta training at the back of the head. You've got to go up to the anterior cingulate to end up dealing with an obsessive compulsive drive. And you either have beta or theta or alpha up there. You look and you know which one you have to target. So we basically ended up with not just doing alpha theta training because of the DSM clustering of you being classified as addicted, which you'd have a 2/3 probability if it was just, well, that's the standard treatment, you'd have pretty good odds, But if you had an anterior cingulate problem, you'd be, you might be clean and sober, but your anterior cingulate will flip onto something else. You'd be addicted to internet or porn or gambling or, So the cingulate's really creative. Sex, drugs, and rock and roll, it will find it, So, so.
Well said, Jay Gunkelman, the pride of 1972.
Well, my North High School, Fargo, 1967, but Bison, 72. So,
Jay Gunkelman, Sky, thanks for clearing up.
Yeah, and Sky's on duty. He acts like a heated, weighted blanket. Keeps me calm, and again, as a bred lion hunter, he keeps the lions away. So
that's your SSRI. That's all you need right there.
Yeah.
Jay Gunkelman, you have a great weekend, man. Thanks for the show again.
Catch you later.
All right, buddy. Bye-bye. The Neuronoodle podcast is supported by listeners and businesses just like you.